Good evening to all the delegates attending this session. As you are aware, in the past 2 years, we have come across many variants of COVID-19 that have affected us in different ways. We had to adapt ourselves to the new normal and follow different strategies to tackle these variants. Amidst these happenings, science and research has progressed further with several breakthrough findings leading us to better insights about COVID-19. Although we have been able to manage the virus transmission and rate of infection through vaccinations and social distancing protocols, it is important to focus on the cutting-edge innovations in COVID-19. With this, I would now like to introduce Professor Dr. Ajit Lalwani. Professor Dr. Ajit Lalwani is the Chair of Infectious Diseases, Director, National Institute for Health Research, Health Protection Research Unit in Respiratory Infections, Director of Tuberculosis Research Center, National Heart and Lung Institute, Imperial College London, and Imperial College Healthcare NHS Trust. Professor Lalwani leads a multidisciplinary program of public health research to protect the health of the population from the most serious respiratory infections such as flu, TB, and COVID-19. Professor Lalwani's patient-based research aims to understand the body's natural mechanisms of protection against TB, flu, and SARS-CoV-2. He translates his discoveries into innovative practical solutions to improve patient care and public health. He has raised more than £38 million in research funding and published over 180 research papers and cited over 12,000 times and widely covered by the international news, print, and broadcast media. Professor Lalwani will be giving us a presentation on the global research update in COVID-19. Over to you, Professor Lalwani.
Pleasure to be speaking at this auspicious and what I believe will be historic conference. And what I'd like to cover is where we are in the global research update on COVID-19, where we are in the pandemic, and what next. I'm going to tell you today about the research I've been doing with my team at Imperial College London to develop new and better approaches to tackle the pandemic. Here shows you some of the papers published to date on different topics, and I'm going to take you through some of these papers. You can see the ones on the left published in Lancet, on the right Nature, European Respiratory Journal. Now, in the key at the bottom of this slide, people in a household, some of whom are fully vaccinated, you can see in the bubble, those who are unvaccinated, no protective shield around them, and then those with waning immunity. So they're in a bubble, but a dashed line bubble. Okay, those waning immunity means people who've been vaccinated, 4, 5, 6 months previously. This is in green, the virus. So we were enrolling contacts in households which had a COVID case. And we enrolled the contacts very soon after exposure, within 5 days of exposure to the virus, meaning within 5 days of symptom onset in the COVID index case. And then we did daily throat swabs of these contacts and did PCR every day. So we could see the point at which they became infected. And we were able this way to capture all transmission happening in the household. And so this study design of attack answered key public health knowledge gaps, particularly around vaccine breakthrough transmission, which is what I'm going to tell you about now, and also around further information that we've been able to answer, which is listed there about the pathways of transmission of the virus. How long do people stay PCR positive after infection? How long does it take for people to become PCR positive? These are all actually important unknown questions in public health that this study has answered. But I'm just going to talk to you now about vaccine breakthrough infections and whether, if you're vaccinated and you get infected, do you infect others? Do you transmit, or does the infection stop with you when it infects you? This simple slide with these red arrows is showing you that fully vaccinated index case on the left can acquire infection. And even though that infection may be mild or asymptomatic, they transmit infection to fully vaccinated contacts. And what we found was that the level of transmission was high. And this shows you that even in a household with fully vaccinated index case, breakthrough infection, fully vaccinated contacts, 25% of those fully vaccinated contacts would get infected. If the contacts were uninfected, the risk of infection was even higher. We found it to be around 38%. Of course, the outcome in those contacts is far worse if they're unvaccinated, as you can see, because then there's risk of severe illness, hospitalization, and death. But we also found, worryingly, that people who had had their second vaccine dose at least 3 months previously, so more than 3 months previously, were at increased risk compared to contacts who've been vaccinated more recently. So this was the first evidence globally that already 3 months post your second dose of vaccine, the protective immunity is already waning. What we found. The y-axis is a viral load of SARS-CoV-2 in the upper respiratory tract. The x-axis is time, days since exposure. And as you can see, within the first few days, the viral load goes up very rapidly. And actually, this growth phase is only 2 or 3 days long. People go from undetectable virus in the throat to peak viral load. And peak viral load is 10 to the 8 virions, or 100 million viruses per milliliter of respiratory secretions. Very high. And that is the window of highest infectiousness. After the peak, the viral load begins to decline, but very slowly. What was the effect of vaccination? Because we studied people who were vaccinated and unvaccinated. And what we found was this, that if you're vaccinated, the peak viral load is actually no different. You would think that if you're vaccinated and then get an infection, what's called a breakthrough infection, at least your viral load would be lower. After all, your illness is milder, but no, your viral load, your peak viral load is undiminished, which is probably why people, despite vaccination, still remain highly infectious to others, especially with Delta and with Omicron. But the effect of vaccination that we saw was faster clearance of infection. You can see the decline or the decay phase of the virus is quicker than in people who are not vaccinated. And that is why if you're vaccinated and infected, you get faster symptom resolution and reduced risk of developing severe disease compared to if you're unvaccinated, right? Because you follow this red viral load trajectory instead of the black one. So you have a better outcome. But your window of infectiousness is basically the same because your peak viral load is undiminished by vaccination. So in summary, whilst widespread vaccination effectively prevents severe illness and death, it only partially prevents transmission of Delta or Omicron. Unvaccinated people cannot therefore rely on the immunity of the vaccinated population for protection. They remain susceptible to infection and at risk of serious illness. Therefore, the higher the vaccine coverage and timely boosters, the better. But sadly, none of this is enough. We need to do better. How are we going to do better? As I tell you the story how we're going to do better, remember the fact that this spike protein in Omicron has evolved away. It's evolved and mutated 38 times, so it's escaping antibody immunity. So what kind of immunity can we induce if the antibody immunity is being outfoxed or outwitted by the mutations in the virus? Maybe it could be the T cells. So this shows you the role of T cells in the response to COVID infection. And you see here the virus is in gray, using the spike protein to enter cells. And you see in green at the bottom, the CD4 T cell, which recognizes infected macrophages. Macrophages infected with the virus. And then the CD4 T cells orchestrate the immune response. They're described as the conductor of the immune orchestra, the CD4 T cell in green there. And the CD4 T cell does many things, but it does two very important particular things. One is you see the arrow pointing from the green CD4 T cell to the green B cell. It provides help to B cells to produce antibody. Great, we know about that. That's what we talked about, the antibody response to the spike protein. But the CD4 T cell does something else. It also helps the CD8 T cells. And the CD8 T cell, shown here in purple, is otherwise known as the killer T cell. It recognizes infected cells in the body, such as airway epithelial cells, that are the cells first infected by SARS-CoV-2 when it enters the body. The CD8 T cells rapidly recognize these infected cells, and they kill the infected cells and destroy the intracellular cargo of the cell, which is the replicating SARS-CoV-2. So these are very effective killer cells, but they're not induced by current antibodies. Right. This shows you what happens after an acute infection with SARS-CoV-2. You get acute infection, so you get a lot of B cells, a lot of CD8 cells, and CD4 cells. And then in convalescence, you get memory T cells remaining. That you look at the far right of this slide, you've got memory B cells that will produce antibody when they re-encounter the virus, and you've got memory T cells, which will produce more and proliferate and become more toxic and kill more cells rapidly if they see the virus again. So both the B cells and the T cells have memory. Difference is, after vaccination or infection, the antibody response to SARS-CoV-2 declines quite rapidly in 3 to 6 months. In contrast, the T cell response declines much more slowly and persists for 2 to 3 years after infection. So please remember that the T cell memory is longer lived than the B cell memory. Okay, now, here's the point. In this slide, you see the spike protein on the surface in red. Okay, but in this virus, this is cracked open. This slide, this picture shows you a virus that's cracked open, so we can peer and look inside now into the core of the virus. And what do we see in the core of the virus? We see the RNA, the genetic code, but we also see proteins that are called non-structural proteins. They are in the core of the virus. They're internal proteins. And these internal proteins are the replicative machinery of the virus. They do the replication of the virus, these internal proteins. The CD8 T cells, the T cell response, is particularly good at recognizing and targeting the core of the virus, the internal proteins. Unlike the antibodies, which see only the surface of the virus and the spike protein. So here's an idea. If the spike protein is mutating away from the antibody response and evading the antibody response induced by vaccines and causing all the infection I described to you earlier and the transmission, so maybe a T cell inducing vaccine could induce T cells and those killer T cells I described to you, T cells that would recognize the internal proteins, and the internal proteins, unlike the surface, do not mutate. They are what's called highly conserved. So between the alpha variant of SARS-CoV-2, the delta variant, and the Omicron, whilst the spike protein has the mutations and is different between the variants, the internal proteins are all the same, highly conserved, almost no mutations. So there's an idea, because then a T cell response to the core proteins of the alpha variant, let's say, should, in principle, be able to cross-recognize the internal proteins of the Delta and the Omicron variants, and thereby be protected. Nice idea in theory. But where is the evidence that such T cells are protective? We have good evidence that neutralizing antibody is protective, as the vaccines work. At least they worked with the original strains of SARS-CoV-2 before the virus mutated and circumvented that immunity. But they work, the neutralizing antibodies. Until last week, there was no evidence that T cells can protect you against COVID. Until this paper. This Nature paper we published at the start of last week, cross-reactive memory T cells associated with protection against SARS-CoV-2 infection in COVID-19 contacts. So this is the second study we launched at the start of the pandemic called Instinct. In this study, we measured, again, it's a study of COVID household contacts. Study design actually very similar to the one I showed you earlier, studying contacts in households. But in this case, we measured in the blood and in their nose all the initial immune responses at the time they were exposed to the virus. Not after they were exposed, not after they got infected, not after they got ill and ended up in hospital. There's no point measuring immune responses then. The immune responses failed in any hospitalized patient. Otherwise, they shouldn't end up ill and in hospital. And that's where all the other scientists in the world focus their energies. We did the opposite. We studied household contacts before they even become ill to see which immune responses early on can predict the outcomes, the clinical outcomes and the virological outcomes. And this was the study design. And what you see here is in red, the index case in the households that I showed you earlier. You can see the red arrow on day 0 where the index case develops symptoms. We call that the day 0. And we would recruit people in the sampling window shown with the blue bracket. In the next few days, we would recruit the orange contacts. The orange arrow is the contact. And we would recruit contacts during those first few days after the index case became symptomatic. And then we would measure their immune response and we would correlate what immune responses they had at that point with the clinical and virological outcome shown on the far right, because we followed up all the contacts for weeks and months. Now, idea was that the proteins, the internal proteins, which are conserved and non-variant between the different strains of SARS-CoV-2. Now, here's the other thing. Those proteins are also highly conserved between the cousins of SARS-CoV-2, which are the beta human coronaviruses. The beta human coronaviruses are well known to all doctors and all patients because they cause the common cold. And they cause about 1/5 of all common colds, right? Common colds are caused by rhinovirus, by adenovirus, and by beta human coronaviruses. Okay. And the internal proteins of the beta human coronaviruses are very similar to SARS-CoV-2, highly conserved, just as they're conserved between the SARS-CoV-2 variants. So using this approach shown on this slide, which the word for this is bioinformatics and epitope prediction. And basically we compared the genomes of the protein sequences of the internal proteins of the common cold beta coronaviruses and SARS-CoV-2. And we found areas that were identical. And in that circle, you can see the yellow, blue, the yellow, turquoise, and blue. Yellow is the SARS-CoV-2. Turquoise is one of the common cold coronaviruses, and blue is the other one. And you can see the red lines cutting across show you the areas where they're identical. The sequence is identical. So we chose peptide sequences that were identical between the common cold, the human coronaviruses, and SARS-CoV-2. And we postulated that the contacts exposed to COVID who had pre-existing T cells in response to the common cold, those who had the pre-existing T cells that would target these epitopes, these internal proteins, and cross-recognize SARS-CoV-2, that contacts with those T cells would be less likely to get infected than contacts who lack those T cells. Here's the result. And in the interest of time, I'll cut straight to the chase, to the goal. And here you see in the black box, top right-hand corner, in blue, but in red, let's look at first in red, those are the contacts who became PCR positive. And on the y-axis, you can see the number of cross-reactive T cells that they had at the time of exposure, right? Cross-reactive T cells that were induced by common cold coronaviruses and could cross-recognize the SARS-CoV-2. And they were all below the threshold. In contrast, to the left, in blue, you see the frequencies of those same T cells in the contacts that remained PCR negative. In other words, contacts who, despite household exposure to COVID, did not get infected. Everyone's wondered about that since the start of the pandemic. Why, in a household, do some people get infected by the case and others, despite breathing the same air and being exposed to the same extent, they don't get infected? What's that about? How could that be? This is the reason. Those that don't get infected have, or at least a good proportion of them have, pre-existing T cells induced by previous common cold infection that recognize the internal proteins of the virus and cross-recognize the SARS-CoV-2 internal proteins. So this result is the blueprint to a universal vaccine, because we've identified here that protective T cells, the T cells that protect us from infection, and their targets, which are the internal proteins. That this paper was covered by 400 news articles around the world. 200 news articles from 380 news outlets on BBC TV, on Bloomberg TV, Sky News, and this just shows you a sample of the coverage. So what next? Current vaccines do not reliably prevent infection with Delta or Omicron variant, nor its onward transmission, even after boosting. A variant-proof universal vaccine is urgently required. As I've shown you, we discovered and published last week the blueprint for this, i.e. T-cell vaccine that targets the conserved internal proteins of SARS-CoV-2. This next generation universal vaccine is at least a year away. It needs construction, clinical trials, testing. So in the meantime, we urgently need better treatments for mild to moderate COVID, which is the usual type of illness in vaccinated persons. And we need such treatments to be safe and affordable. And I think there's no better way to end this talk than to shine a light on the need for urgently needed better treatments for mild to moderate COVID. And I hope you enjoy the next sessions listening to how exactly that is being delivered now and available to you. Thank you and goodbye.
Thank you, Professor Lalwani, for that detailed overview of the global research update in COVID-19. This leads us to our next speaker, Professor Dr. Shashank Joshi, who will walk us through syndrome of Omicron variant in COVID-19, focus on symptomatic relief. I would like to introduce Professor Dr. Shashank Joshi, who is a Padma Shri awardee. He's the member of COVID-19 Maharashtra State Task Force. He's a chair of the International Diabetes Federation Southeast Asia and a consultant endocrinologist at Joshi Clinic and Leelavati Hospital, Mumbai. Over to you, Dr. Joshi.
So if you have lived where hurricanes happen year after year, you might not want to take away all the hurricane precautions just because the storm is dying down. So Omicron is a new variant in COVID-19 space. And it's a syndromic symptom-based relief, which we are looking at, and that's what I'm going to allude to today. So compared to the Delta variant, which was prevalent worldwide, suddenly we have a super mutant variant of concern called Omicron, which is illustrated in this diagram. It has increased risk of reinfection compared to other variants of concern. It is a very most heavily mutated variant as far as we are concerned. It has enhanced transmissibility and partial resistance to vaccine-induced immunity. So it is rapidly transmitted. R0 is unknown. It has replaced Delta very quick, very fast worldwide. It is more transmissible. It has probably a breakthrough which is common with immune escape. Severity and virulence is unknown, but very clearly it is less severe. And early trends are that it is less virulent and probably a mild disease. But from an Indian standpoint, we want to save every life. And in India, we know the COVID risk score, which I wrote in May 2020 at the beginning of the pandemic. Age more than 55, male gender, hypertension, diabetes, obesity, chronic heart disease, chronic lung disease, chronic kidney or liver disease, any congenital acquired immunodeficiency, steroid immunosuppressants or transplant, all of them confer a risk. We have a very high insulin resistance and a cardiometabolic burden, which is why we need to be very careful. So it is these comorbidities which increase the risk of hospitalization, with asthma, hypertension, obesity, diabetes, chronic kidney disease, or many of these conditions. So when we see a patient with COVID today, essentially we have these subtypes: unvaccinated without any past COVID, which is called naive infection. Then we have breakthrough, which means partial or total vaccination or an extra dose. Then we have reinfection, which means past COVID-19, or we could have a combination of breakthrough and reinfection both. Typically, COVID has a flu-like syndrome in most people in the early Delta wave. Then, of course, the second stage is pulmonary phase, where there is shortness of breath. And then, of course, there is a hyperimmune, hyperinflammatory response. So typically, we had febrile illness, upper respiratory symptoms, cough, cold, sore throat, 80% in the first wave. The 14% had severe symptoms going to the lungs. So we had a nose throat COVID, lung COVID, and then, of course, all over the body. But in the Omicron timetable, 95% are syndromic and symptomatic. 4% might go to the lungs. That's very rare, very, very unusual. And only 1% may have severe disease. So in this current flu-like syndrome, particularly in the winter season, Delta, there is dry cough. Omicron, there is cough, but it could be productive. Flu, there is dry cough. Cold, you will see common cold. It is common to have a little bit of mild cough. Runny nose is seen in both Delta and Omicron, sometimes in flu and of course in common cold. Sneezing is common in Omicron and cold both. Sore throat and bad throat and painful throat is very synonymous with Omicron, but can be also seen in Delta, flu and cold. Shortness of breath is synonymous with Delta. Fever can be low grade or high grade both in Omicron, while it's common in Delta and flu. Cold, it may be very short duration. Night sweats occasionally are seen with Omicron, which are not seen with Delta, flu and cold. Chills are common in Delta and flu, not so common in Omicron and cold. Headache is common and backache is very common in Omicron, but it can also be seen in flu and Delta. Loss of smell and taste is typical of Delta, rarely can be seen in Omicron, or usually not seen. And in flu and cold, it is definitely not seen. Fatigue is very, very common, and myalgia, severe myalgia with Omicron can be occasionally seen with Delta, flu and cold. And the symptoms take around 4 to 5 days in Delta. Omicron, it could be 1, 2 or 3 days. Flu, it is probably 2 days, and cold, it is 2 to 3 days. So typically, when we see allergic airway disease and SARS-CoV-2, in the eyes, we see typically in allergens, you get red, watery, itchy eyes, while in SARS-CoV-2, you will get conjunctivitis. In the ear, you will get itchy and buzzy ear, while in SARS-CoV-2, you will get a little bit of dizziness. In the nose and mouth, you will see runny nose, sneezing, itchy nose, palate and throat. And sometimes you might get cough and wheezing. While in SARS-CoV-2 or COVID, you will get loss of smell and taste, sometimes sore throat or bad sore throat in Omicron, fever, dry cough, shortness of breath, and fatigue. And clearly, it is very important to distinguish allergic rhinitis, COVID, and influenza. Cough, headache, fatigue, sore throat, nasal obstruction, rhinorrhea is common to all. Fever, chills, muscle, body ache, shortness of breath, acute loss of sense and smell, vomiting, nausea, diarrhea is more common in COVID and influenza. And sneezing and itchiness is more common in allergic rhinitis. Ultimately, how the virus responds depends on how good our immunity is, how adaptive our immune response is, whether we are clearing the virus quick and fast or we are deteriorating. And we have the NLP3, which means when SARS-CoV viroporins enter, there is a lysosomal disruption, the Golgi membranes are disrupted, and the inflazome of NLP3 is activated, and you get cellular release of cytokines. Also, it is very crucial to understand prostaglandins, TNF-alpha, IL-6 is very, very crucial in the pathogenesis of the symptomatology and syndromic diagnosis of COVID-19 as illustrated in this diagram. So typically, most people have a normal post-survival, non-lethal infection, immune recognition, immune recruitment and resolution with a good immune response, and return to homeostasis with clearance. Rarely will get immune evasion, delayed or inadequate immune response, a lot of cytokine storm, and probably death and sepsis. So it is how fast our virus is recognized by various ligands and how quick the local tissues fight that viral response. And this could be a fast innate response or it could be a slow antibody response, as has been illustrated here. So clearly in SARS-CoV-2, we have IL-2, IL-4, which is the adaptive immunity, which is good. We have anti-inflammatory cytokines like IL-10 and the bad pro-inflammatory cytokines and interleukins like interferon gamma, the IL-1, IL-6, IL-17, and TNF-alpha. And this is how the immunopathology of COVID unfolds. Lymphopenia, T cell activation, lymphocyte dysfunction, granulocytes and macrophages are abnormal, cytokines are produced, and antibodies are increased. And that's what Dr. Lalwani has beautifully told us about the T cell role. And then, of course, you can get a cytokine storm, you can get lung injury and death. So typically, we are definitely seeing this. And we are in the era of evidence-based medicine. If you do a simple CBC with RDW and neutrophil to lymphocyte ratio with CRP, we can easily pick up the early nose and throat COVID and inflammation. If you do a D-dimer ferritin LDH, it is useful with IL-6, but a CBC with RDW of more than 14.5, you are likely to progress with an increasing CBC. COVID-7, vital 7 monitoring is the key in COVID management. If your temperature is persistently above 100, you need anti-inflammatory, stroke, antipyretic drug. If he is persistent tachycardia, persistent respiratory rate which is high, blood pressure or glucose which is high, you might need admission. The COVID stethoscope is pulse oximeter, where you see the oxygen saturation. If it is below 93% or after a 6-minute walk test, it is below 3% drop, then again we need to red flag the patient and keep connected with the patient. Take the pulse oximetry reading properly after resting, without a mask, without talking for a few minutes, in the middle of ring finger, removing the nail polish, and warm the cold extremities and wait for 60 seconds. Typically, the therapy is all symptomatic and syndromic in the current space. And this is what Government of India has come out, that you can easily manage most people at home for the simple flu-like syndrome. And if there are elderly people above 60 with comorbidities, you might sometimes, or immunocompromised states, you might put them in the hospital. So isolate in a good ventilated room, use a proper mask, ensure the caregiver is taken care of, take rest and hydration, follow respiratory etiquette, maintain a good hygiene, do not share your personal items and monitor saturation levels. Most important is, be teleconnected with your doctor, continue medicines for comorbidities, follow symptomatic management of fever, number 1, running nose and cough. So for running nose, take an antihistamine of your choice, a fever, antipyretic or anti-inflammatory medicine, and for cough, perform warm water gargles or steam inhalation. Try to see that antipyretics are properly taken. Don't get misled by information through social media, and don't self-medicate. Do blood tests or radiological tests without letting a doctor, and do not misuse steroids at all. They can be deleterious in home. So obviously that is what we need to do, and ensure that the biosafety guidelines and COVID appropriate behavior is done very, very carefully. Whom should we admit? If somebody has difficulty in breathing, persistent fever for more than 3 days above 100, dip in saturation less than 93%, or respiratory rate is more than 24, persistent pain in chest or persistent pain, mental confusion or inability to arouse, severe fatigue or myalgia, you should straight admit the patient and not think twice. And of course, we can discharge them early in Omicron world and rotate them. There is a role for inhaled budesonide or a steroid if there is persistent cough more than 3 to 5 days, but there's a lot of caution. Allergy can be easily treated with antihistamines, and there's a lot of allergy and allergen avoidance in there. And we basically need to ensure that we attack inflammation. We downregulate the NF-kappa beta very quickly and fast. And we also know that people, whether it is COVID Delta, COVID Omicron, there is a risk of thrombotic disorders. Because whenever there are respiratory symptoms, thromboembolism goes up. It's a thromboinflammatory stage, and therefore there is a definite need to understand that there is a complement activation, thrombotic activation. People at risk should be red flagged. It's very important if you have cardio-diabetes, obesity, chronic kidney disease, immunocompromised state, transplant patients, COPD, obesity, elderly, they are at risk for death. You can score them. Solid organ transplants, blood cancer patients, dialysis, immunosuppressive, immunodeficiency need more therapy. So we must find out who is at risk to die. Sometimes we can give them these monoclonal antibodies. Some of them work in Omicron, some of them in Delta, like the sorotovimab or the casirivimab and indivimab. And they are useful only in those very, very high risk categories. But the disease is most transmissible in the first 5 days of symptoms. And therefore, we need to try to treat them symptomatically as early as possible. We have some modern age drugs like, say, an antiviral, which are not available in India, like nirmatrelvir or ritonavir or molnupiravir, but they have their own limitations. And most of the patients above 60, below 60 do not need these drugs at all because they cannot be given in pregnancy, they cannot be given in lactation and have select use in that. Monoclonal antibody, molnupiravir or the nilmetavir, ritonavir combinations can reduce, it should be only used in high-risk population, are expensive, reduce the hospitalization only by maybe 7%, 3% or 6%. And that is where they stand, but they have some role. I don't say that they don't have any role. And this is how the COVID space looks like. But main treatment in Omicron world is not hospitalized. Symptomatic patients need a syndrome-based care. So if somebody is asymptomatic with comorbidities or no comorbidities, you just need to observe them. Somebody is symptomatic without fever, with rhinitis and cough, again symptomatic treatment. If you have symptoms with fever, again symptomatic treatment, sometimes you can use an antiviral above 60 with more than 2 comorbidities. That's the protocol. And of course, you should know when to admit, when not to admit. That's the key. So fundamentally, what we are trying to do, the modern protocol with COVID is fundamentally symptom-based management. It is all boiling down to managing the nose COVID, the throat COVID appropriately and correctly. Managing the little bit of sneezing, the nasal congestion, the sore throat, as well as a symptom-based relief, apart from cough and fever. So obviously, we are trying to get newer and newer targets, either through cellular signaling, through viral-dependent RNA polymerase, antivirals, vaccines, modulation of immune therapy, gene therapy, and even nutraceutical supplementations. So all of them make a part of the integral therapy. What are we today? As we talk today in COVID, we want 0 COVID deaths. We want no severe disease. COVID treatment is all symptomatic and syndrome-based. It's a mild, manageable endemic disease. And probably Omicron is a chain breaker in that direction. So when we talk in January 2020, we need to be responsible. We know COVID is predictably unpredictable. We need to save lives. But Omicron treatment, as of today, is a symptom-based syndromic approach, apart from ensuring that we red flag those high-risk individuals. Most of the patients can be managed at home by good symptomatic management. And that's all it takes to conquer this illness. Thank you for a patient hearing.
Thank you, Professor Joshi, for walking us through the symptomatic relief in COVID-19. Now we move on to another cutting-edge topic, first in the world innovation by Vitabiotics in COVID-19 by Mr. Rohit Shilatkar. Mr. Rohit Shilatkar is the Vice President and Director of Vitabiotics Limited. He is an accomplished modern thinker and a leading keynote speaker at several medical symposia. In his 18-year spell at Vitabiotics Limited, Rohit has held 4 important positions within 4 years. He was elected as a member of the board in his 5th year and has recently been named Vice President. Vitabiotics Limited is UK's #1 and fastest growing company and has manufactured innovative healthcare supplements, including significant advancements in men's, women's, and children's health. The company has been awarded the Queen's Award for Innovation in Vitamin Research, which was personally received by Rohit from Her Majesty the Queen on behalf of Vitabiotics Limited. Rohit has been involved in over 100 new product developments and has played an essential part in the development of the business and Vitabiotics products in over 100 countries. Furthermore, Rohit has been invited to deliver lectures to medical consultants and postgraduate students in several medical symposia organized by leading medical organizations. Rohit is also the chief inventor of Asprinol 19. I would like to introduce Rohit Shilatkar. Over to you, Rohit.
Good evening and welcome. Hope you are all well and safe. Today we'll be having a look at Vitabiotics' special innovation in the symptomatic management and treatment of COVID-19. This formula that would be launched under the name of Asprinol 19 would be a synergistic combination of aspirin, which is an antithrombolytic agent with some antiviral effects, plus promethazine, which is a commonly known antihistaminic, along with a vitamin and mineral mix that includes vitamin C, D, B3, zinc, iodine, and selenium. All of them are known to have their anti-inflammatory, antioxidant, and immune modulating effects. Each tablet is to be taken twice a day or as required. Triple action is defined as follows: exerting an antiviral effect along with symptomatic treatment of the flu-like symptoms and boosting the natural immune system for short and long term. We have filed the world's first patent in this category of symptomatic COVID treatment using this synergistic formulation. Let's have a look at how aspirin works in COVID-19 patients. Studies have shown that drugs that block COX-2, thereby reducing the manufacture of prostaglandin E that helps virus multiply, can have antiviral effects. Aspirin makes cells stop producing prostaglandin E2. Aspirin may also work on different immune cells and show its immunomodulatory effect on both innate and adaptive immune responses. In vitro studies have shown aspirin's antiviral effects by blocking influenza virus, which is an RNA virus, propagation via NF-kappa B inhibition. Hence, it may be worth looking at the effect of aspirin in treating COVID-19 patients. Here are some latest references which explain the exact thing that I explained in the previous slide. The first reference from Drugs Volume 80 explains how aspirin use is associated with lower rates of clinical complications and in-hospital mortality of COVID-19 patients. The second reference from Scandinavian Journal of Immunology shows how aspirin exerts stimulatory effects on the production of pro-inflammatory cytokines in whole blood. Aspirin shows a dose-dependent immunomodulating effects on pro-inflammatory cytokine production. The latest reference from Anesthesia and Analgesia explains how aspirin decreases the production of IL-6, CRP, and macrophage colony stimulating factor, thus reducing the incidence of cytokine storm. The next reference here from the International Immunopharmacology states that aspirin has immunoregulatory potential in relevance to immune tolerance. It also displays some intriguing trials to modulate the innate and the adaptive immune responses. Lastly, this last reference also shows how aspirin has a significant antiviral activity against DNA and RNA viruses, both, including different human coronaviruses. Here are some references which explains the role of promethazine, our second drug in the combination. The first is aspirin, the second is promethazine. So here are some references, some latest references that I have put together that show and explain the role of promethazine in COVID-19. The first reference from Biomedical Research International, published in 2013, explains that promethazine has been used in treating symptoms of asthma, pneumonia, or other lower respiratory tract infections. The second reference is from Clinical Allergy Immunology, states that antihistamines block airway inflammation, bronchoconstriction caused by histamine release from mast cells. And the next reference from the International Journal of Infectious Diseases 112 explains how mast cells activation and histamine release may contribute to the inflammation associated with COVID-19 infection. Promethazine also decreases inflammation and enhances barrier function, acts as a cough suppressant, acting on the part of the brain to reduce the need to cough. It also has shown to present antiviral activity, including against MERS coronavirus and SARS coronavirus 1 in vitro, and has high efficiency in improving the therapeutic outcomes in COVID-19 patients. This reference from Nature Medicine explains how patients with coronavirus 19, COVID-19, have systemic elevation of pro-inflammatory cytokines IL-6 and TNF-alpha. The next reference here from International Journal of Infectious Diseases states that overactivation of mast cells and release of cytokines might also have a role in the development of pulmonary fibrosis in COVID-19 patients. Promethazine is shown to have positive impact in both of the above two indications. The reference from Bioorganic Chemistry explains how promethazine has already shown to present antiviral activity, including against MERS coronavirus and SARS coronavirus 1. In addition to other classes of medications, antihistaminics such as promethazine have high efficacy in improving therapeutic outcomes in COVID-19 patients. This has been shown in some clinical trials, as well as some clinicians, some doctors have shared their first-hand experience in just using promethazine in treating coronavirus patients without a single death or need for hospitalization. Promethazine has shown to decrease inflammation and enhances barrier function. We all know micronutrients have potential roles in interfering with viral entry and inhibiting replication cycle of severe acute respiratory syndrome coronavirus. Micronutrients have immunomodulating, anti-inflammatory, antioxidant, and antiviral properties. Therefore, micronutrients are a consequently promising alternative approach to combat coronavirus COVID-19. Zinc. We're going to talk about those ingredients that are included in this aspirinol 19 formulation. So we have spoken about aspirin and promethazine and how they work. We're going to talk about the vitamins and minerals and how they work. And also later in this presentation, I'm going to also explain why certain levels of these vitamin and minerals are essential in the treatment and management of COVID-19. So let's start with zinc. Zinc, as we know, prevents viral entry and suppresses its replication. It prevents high level of inflammatory mediators. It has immunomodulatory, antiviral, and anti-inflammatory responses, and has an antiviral effect by blocking virus attachment, infection, and uncoating. And these are the references I've cited on this slide, which will explain what I've just said. Next, let's have a look at vitamin D and C and the role in COVID-19 treatment. Vitamin D is shown to attenuate acute lung injury, modulate adaptive immunity, and improve cellular immunity, and downregulate pro-inflammatory cytokines. Several hundreds of clinical trials have been done in the past 2 years to show the immune modulatory effect and suppression of inflammatory cytokines in COVID-19 patients using vitamin D. Vitamin C is shown to help restore proper lung function and prevent and help management of oxidative stress and cytokine storms. Although there are hundreds of references supporting these claims I've just made, I've mentioned a few latest and most relevant ones on these slides here. Iodine supports the innate immune system in fighting viral infection and has a powerful antiviral action with an anti-hemoglutagenic effect. Niacinamide has been found to decrease IL-6, IL-1B, and TNF-alpha in stimulating alveolar macrophages, indicating reduced inflammation and enhances the therapeutic efficacy of antiviral agents and immunotherapy to treat fatal COVID-19. Selenium affects blood coagulation and thrombosis formation, and selenium deficiency is related to oxidative stress and hyperinflammation seen in critical COVID-19 cases. Now I'll explain you why we have these certain specific levels of ingredients in aspirinol 19. In addition to obtain a significant inhibition of platelet activity and aggregation, a high level of COX inhibition is necessary. This result can be obtained rapidly by using higher aspirin doses, 300 mg daily. Oral vitamin D supplementations of about 4,000 IU for 10 days is significantly more effective in reducing virus replication and controlling the cytokine storm. This has been shown in several clinical trials, several hundreds of clinical trials all around the world over the last couple of years. Clinicians have really taken vitamin D supplementation as not just a preventative measure, but also it is considered very seriously in treating coronavirus. Dosing recommendation of vitamin C is suggested to be optimum at a daily intake of 1,000 to 2,000 mg. Supplementation of 15 to 30 milligrams of zinc per day in COVID-infected patients is seen to be effective. Zinc has immunomodulatory, antiviral, and anti-inflammatory responses at these doses. Selenium, again, has beneficial effect on cellular immunity with significant higher T cell proliferation with up to 100 micrograms per day. And now we'll talk about the current clinical trials that we have on this formula aspirinol 19. The first trial was done at Lokmanya Hospital in Pune, and then we have some ongoing trials, one of which is done in Nasik, one in Bangalore, and one in Kerala. The Kerala and Bangalore clinical trials results are not yet out, so I don't have those with me to discuss today. We will be publishing those results very soon, but we'll be briefly discussing the results from the Lokmanya Hospital Pune trial, and the other trial which is currently ongoing in Nasik. We have some results to share with you today. The first trial that was done at the Lokmanya Hospital in Pune, it was a randomized controlled clinical trial to assess the efficiency and safety of Asprinol 19, our new product, in mild symptomatic subjects of COVID-19. The trial consisted of two groups, totaling to 60 people, 60 patients. The first group received paracetamol and various other antivirals and some vitamins, whilst the second group received a specific combination of Asprinol 19. These were given twice a day over a period of 10 days. The primary objectives were to evaluate the improvement of clinical symptoms of COVID-19, such as fever, headache, cough, etc., to evaluate the reduction in elevated levels of inflammatory markers and changes in blood oxygen level. Secondary objectives of the trial were to evaluate the requirement of hospitalization and admission rate in the ICU. After 10 days of treatment, the group that took Asprinol 19 showed 83% reduction in cough, whereas the control group showed 52% reduction. Asprinol group showed 76% reduction in breathlessness and 69% reduction in fatigue, compared to the standard group of 41% and 62%. Asprinol group also showed 62% reduction in myalgia compared to 31% in the control group. Inflammatory markers like CRP, LDH, and ferritin were elevated in both groups at baseline. There was a statistically significant reduction in the elevated levels of serum LDH and ferritin levels between treatment and control groups. You can see 27.3% reduction in LDH in the Asprinol group as compared to control treatment, 47.96% reduction in ferritin from screening, and 60% reduction in CRP from screening. After 10 days of treatment, we saw no hospitalization, no oxygen supplementation, and no mortality in the Asprinol 19 treatment group. This is phenomenal. 10 days of treatment, not a single case of hospitalization, no oxygen supplementation required in none of the patients, and also, as I said, no one died, no mortality in the Asprinol 19 group. And this is the ongoing clinical trial at Nasik. It's not yet completed, but very soon to be completed by the end of this week. Next week, it would be completed. And here you see analysis for 35 subjects and change in the inflammatory markers, reduction in D-dimer levels, reduction in ferritin levels, reduction in the CRP levels, and reduction in the LDH levels, all following treatment with Asprinol 19 just for 10 days. So in summary, we see speedy clinical recovery. We saw that not a single patient was hospitalized, not a single patient using Asprinol 19 was hospitalized. All the subjects were treated at home. All subjects recovered without a single mortality. Nobody died, and none of the subjects, none of the patients required supplemental oxygen or hospitalization. These are really outstanding results. And as a recommendation, instead of using paracetamols and other standard antivirals, consumption of aspirin, promethazine, along with these multivitamin and minerals, should be supplemented for relief in case of all flu-like symptoms observed in COVID-infected patients. Thank you very much.
Thank you, Rohit, for the wonderful presentation on the innovation by VitaBiotics. I would now like to invite all the speakers for a panel discussion and ask Dr. Joshi to moderate the same. Over to you, Dr. Joshi.
Thank you so much, Anirudh. Professor Ajit Lalwani was simply outstanding. Your work in the T-cell paper of Nature is quoted worldwide. Your paper is giving us a lot of hope in the current hype of speculation. You have generated some high science and high evidence. So congratulations to you, Professor Lalwani, for continuously, being committed to the cause of tuberculosis. Professor Lalwani is one of the foremost global experts in tuberculosis and immunology, but now currently has given us an insight in the immunology of COVID. So the first question is to you, Professor. Lalwani. It's a very simple question. There are some similarities between influenza and SARS-CoV-2. Could you throw some insights in the similarities?
Similarities are that they are both RNA viruses. They are both highly contagious, and they are both capable of causing pandemics, as we've seen, epidemics, but also pandemics. And the other very important factor of clinical similarity is that both of them are much more severe in the elderly and in people with pre-existing illnesses. So every year in the winter season, if people die from flu, it's nearly always the elderly. And so with SARS-CoV-2 also has a predilection for the elderly. But in addition, interestingly, the body mass index, weight, these are very big risk factors with COVID, but less so for flu, but really remarkable for COVID. It's almost as if the COVID is adapted for the current global population, because the current global population is aging, but also it's generally overweight. And these chronic non-communicable diseases that are so prevalent in India particularly, so firstly, being overweight and obese, increased visceral fat, chronic ischemic heart disease, and particularly diabetes, these are all huge risk factors for COVID severity, much more so than flu. So they're similar, but there are key differences as well.
So that leads me to the second question to you, Professor Lalwani, before I go to Rohit and maybe a couple of questions to me, is that, influenza stayed with us for almost ever. So will COVID also stay with us forever? And do you really feel that Omicron is nearing the gap between flu and COVID? Do you feel it's a milder variant? It's a less severe variant? Do you really feel that it's like the end of the tunnel after which we'll have flu-like syndrome, but probably not the fatalities which we saw in the earlier waves?
This is a very good question, Dr. Joshi. And I think the short answer is yes, that successive variants of SARS-CoV-2 are, although becoming more and more transmissible. In the case of Omicron, it's also becoming somewhat milder. And it's milder for two reasons. Firstly, the virus itself, the Omicron variant, is intrinsically milder because it replicates less well in the lower respiratory tract than the previous variants, but it incidentally replicates better in the upper respiratory tract, which may be part of the reason why it's more transmissible. So it's intrinsically less virulent. But secondly, Omicron has arrived at a time when most of the populations are vaccinated. So that also means that those who get infected because of previous vaccination have a milder course of illness. So there are two independent reasons why the Omicron epidemic is milder. And of course, Omicron is, as we know, a vaccine escape variant. 38 mutations in the spike protein that enable it to circumvent protective antibody responses, as I outlined in my lecture. So yes, SARS-CoV-2 in the past is becoming endemic, and yes, in years to come, we will consider it to be rather like flu. But because of the propensity for mutations, similarly to flu, we'll have to update vaccines every year. But as you know, that means we're always one step behind the virus. And so the alternative approach I put forward, and which you nicely summarized the implications of our recent Nature paper, is that there is real scope, or we have delivered the blueprint for developing a universal T-cell inducing vaccine, which would not need annual updating for different variants, because it would be able to tackle all the different variants.
Thank you, Professor Lalwani. I'll come back to you for a question or two a little later in a field which you work also very actively. And as I transit into Rohit, a couple of questions which I can see here, which have cropped up from the audience is that do you really need, there's a need for oral treatment? Is there really a need to start antithrombotic? Absolutely yes. As I said in my talk, that this is a thromboinflammatory disease, though there is a flu-like syndrome. And as Professor Lalwani said, that it is made for the current environment. So in the zone of non-communicable diseases like India, where we have visceral obesity and a propensity to develop cardiometabolic syndrome or diabetes and hypertension and heart disease, having an anti-thrombotic agent, definitely, that's the second question asked to me, is a need of the hour. And many a times we continue it for 3 months. And we have seen this in COVID, because we have often found that people who survive COVID, they sometimes get sudden cardiac deaths or get cardiometabolic complications much later after they have recovered from COVID. And remember, the post-COVID or the long COVID, which we didn't discuss today because our focus was acute COVID, sometimes lasts even as long as 3 months up to a year. And all over the world now we are worried about that. And we don't know whether there will be a long COVID coming out of Omicron because the data is too short and too small. So Rohit, you are an innovator. You have a lot of pharmaceutical and pharmacy and pharmacology background. You go to the top UK universities, including Oxford and Cambridge. What really prompted you to do this formula? What made you select these ingredients? Why did you do this mix and match combination? It looks very compelling. I found that this combination is very attractive. I had some samples from you all and I have used it in a few patients. I found it pretty useful, particularly for the symptomatic variant, because you have an antihistamine which clears up the nose because the nose gets very badly clogged. And then of course you have a little aspirin which has a dual impact. It works like an antipyretic, anti-inflammatory. It also has a cardiometabolic protection role. And then of course you have some micronutrients. All this is still in a speculative space to an evidence-based space. So it's work in progress. But what made you think of all this? I mean, did you have something similar in United Kingdom? Because that you live in a colder environment, and flu is a common parlance there, as Professor Lalwani told us. So Rohit, what was your thought process behind this?
Thank you, Ajit. We thought of this combination was really work. Viruses and if they replaced us right from we saw that antibody.
There's some problem with your echoing with your audio. Would it be okay if you could just try to correct it?
Yeah, Dr. Joshi, while the audio gets fixed, may I make a couple of comments on Rohit's behalf? He'd probably be too modest to say it himself, but I'd like to pay tribute to his tremendous, fast, dynamic work. He is a dynamic Maharashtrian pharmacologist, and he has conceived this formula together with my father, Dr. Lalwani, also Professor Lalwani, and taken it through clinical trial and approval by DCGI, Drug Controller General of India, in record speed. And this is something which I feel I should say on his behalf because he's too modest to say it himself. And as he fixes the sound at his end and tells you, what I would add is that aspirin is not only a double effect, it's actually a triple effect because it's antithrombotic, it's anti-inflammatory, as you rightly emphasized, but it's also antiviral. And the way in which it exerts antiviral effect is through the host response, because it improves antiviral interferon cytokine release. So it has, through modulating host response, it helps the host to maximize its own antiviral defenses. And the same is true of the other micronutrients in Aspirinol 19, which hopefully now his sound is fixed and he would be happy to tell you about. And if the sound is not fixed, I'm happy to continue to explain.
Then I'll ask the next question, which are really close to your heart. Rohit, can you?
I've gotten rid of my AirPods, so hopefully.
Oh, good. This is better. That's better. We can hear you now.
It's much better, yeah.
Yeah.
So the secret of your formula
Yes, yes. The virus is difficult to treat because it's replicating in human cells. Right from the beginning of the pandemic, we saw that
Maybe speak up a bit,
were.
please, Rohit. Can you speak up louder, closer?
Is it better? Can you better? Yeah.
Yeah.
We saw that antivirals didn't quite achieve what we expected them to do. While some anti-inflammatory drugs reduce the risk of deaths from COVID, and of course vaccines helped a lot, but these anti-inflammatory drugs were only given to hospitalized patients, people who had severe COVID-19 and who were in the hospital. We were looking at drugs that can be taken at home in a tablet form that stop people ending up in a hospital on a ventilator. It takes years to develop an antiviral drug, and hence looking at reusing existing drugs that are easily accessible and treat the symptoms of COVID was the need of the hour. There is a wealth of knowledge and very detailed science substantiating the use of aspirin, as Professor Lalwani has just mentioned, use of aspirin and promethazine treating flu-like symptoms that are seen in COVID patients. And of course, the mineral and vitamin combination used in the formulation also has rich scientific data supporting its use at the levels we have used in aspirinol in treating those flu-like symptoms in COVID-19. So that was the main reason. These were the combination of reasons why we came up with this unique mix.
And Dr. Joshi, may I pick up on one point that Rohit made there, please? Sure. Yeah, thank you. As when he used the very appropriate term, the need of the hour, this I tried to get across in the closing minutes as the conclusion of my lecture, which is that with the Omicron variant that is evading vaccine-induced immunity and also tending to cause a milder illness, what is the need of the hour? Clearly, we need better vaccines, but they're going to take a few years to develop, as I described. So the need of the hour now is a widely available, safe, affordable treatment for relatively mild illness. So ambulatory illness in the community. Not so much for hospitalized cases, because hospitalization with Omicron in vaccinated populations is rare, because the vaccines, even if they don't protect against infection, they still, fortunately, prevent against severe disease. So the need of the hour is very widespread, growing rates of infection with a relatively mild illness. And this is where Aspirinol 19 fits into the doctor's toolkit, to the armamentarium. For all these patients, community, in the community, ambulatory, ill but not severely ill, this is a very potent agent. And as we already heard, the triple effects of aspirin, plus the promethazine, plus the micronutrients, all of which, as Rohit nicely outlined in his lecture, all of those help the immune system to fight the virus. So it's really very much a way of almost like an immune enhancement to maximize the body's own defenses to deal with the relatively mild but nonetheless still debilitating illness that is COVID these days with Omicron. And each of the ingredients he mentioned plays a crucial role in the immune response. And probably we will come to see in the next months that zinc is perhaps one of the most critical of all in reducing, a good zinc level for reducing the viral load and the symptom burden.
Absolutely. So, Professor Lalwani, I'm going to come back to you. You are the discoverer of the TB spot test, which is world famous now. You have done some cutting edge work in this whole space. One very important question is that people who get severe disease, they tend to get a long lasting immunity compared to people who get mild disease or moderate disease. This has been in the minds of clinicians, researchers, and lay people. Unfortunately, today, as I said, COVID started with wild speculation, went to informed speculation, then went to evidence base. You are at the center of evidence base. So how do you view this particular phenomenon? That is it true that patients with severe COVID have a long lasting immunity compared to people who suffer from mild to moderate infection? And when that analogy is applied to Omicron, they will get mild disease. Would they get less immunity naturally, and they may be more vulnerable to get recurrent infections?
It's another really great question, Dr. Joshi, and I think the audience should be grateful for the very good questions you're asking, because they bring out very informative answers. Now, on this one, the short answer to your question is yes. So the more severe the COVID illness, the longer lasting the immunity. But two caveats to that, because as you rightly say, if that's the case, it's rather worrying. And it is rather worrying, because you need then a bout of severe COVID, maybe being hospitalized and so on, to get a long-lasting immune response. And if you get mild illness, like most of us, and as will happen increasingly, as we said with Omicron, the immunity will be shorter lived. It's a bit of a problem. But here are two caveats. One is that this decline, the rapid decline in the first few months after illness in the milder cases, this decline is mostly the case for antibodies. In the case of T cells, they tend to persist longer, whether the disease was mild or severe. Yes, if it's severe, the T cells persist even longer, but even with mild illness, T cells persist longer than the antibodies. Secondly, indeed, I can tell you, when I had COVID myself back in March 2020 in the first wave, I monitored in my own research laboratory my antibody and T cell levels afterwards. And within 4 months, my antibodies were almost undetectable, but the T cell response was still strong and kicking. The second caveat is that although the immune response declines with time, as you can imagine, like most clinical and biological variables, it has a normal distribution, like a bell-shaped curve. So most people, let's say their immunity is declined at 6 months. Okay, so then the peak of the bell-shaped curve, the normal distribution, is at 6 months. In some people, however, it's declined earlier, and in others, it's declined more slowly at 9 months, 12 months, longer. And so by studying the determinants of a longer-lived immune response, even in those with mild illness, one should be able to understand how to make vaccines induce longer-lived immunity. So those are a couple of just more cutting-edge scientific, research-type insights to make a more nuanced answer to your question. But the short answer is yes.
Thank you, Dr. Lalwani. I'm going to come back to one or two questions. Avinash Kenikar is asking a question. I can see that to you, which is related to BCG, and that's an area which I work on also. So I'm going to ask you that a little later. Rohit, a lot of people have asked the question: are there any side effects? Are there any contraindications? Is it available in the market? This has been asked by Swati, Gajanan, Vikas Shukla, Dr. Vikas Shukla, and so many others have asked this question. So, obviously, whenever a medication or a formulation is launched, these are the standard questions, any adverse events, any contraindications, and so on and so forth. And then I will just quickly make a passing mention on micronutrients, which Professor Lalwani was also alluding to, because all these micronutrients which are packaged have some degree of power, but they also have a lot of critique with it. So is it the dosing which matters? So we'll discuss that a little later after that.
Dr. Joshi, your questions are about availability of the product in the market right now. Yeah.
Yes.
So the product is available. We had a launch on the 20th of this month, which was last Thursday. Since then, the product is available. It's available at major pharmacies, even smaller pharmacies around the country. Prescriptions have started coming in already. We have made a soft launch with presentations and conferences like these. More doctors, more clinicians would be aware of this product. But yes, if you were to write a prescription today, and if your patient was to go to a local pharmacy to find the product is available.
Fair enough. The second thing is, what are the contraindications, any adverse events which were observed in the trial?
There was no adverse event observed in the trial, and the biggest evidence of that is all 60 continued with the trial. There was nobody who came out of the trial before the trial was complete. It was only a 10-day trial and 60 patients. We still continue to do more trials. We can't see any contraindications with or ADRs. When it comes to interactions, etc., people have asked me questions, separately, doctors who I have spoken to, in India and overseas about when it could be given, when it should not be given, etc., etc. And people have talked about aspirin, whether they could be given with certain other medications, etc. See, when we talk about interactions, every drug has interactions. Aspirin, if you check all the interactions with aspirin with other medications, there are 360 drugs with which aspirin would have interaction. That doesn't necessarily mean they would be contraindicated. It's all dose dependent, as Professor Lalwani said, and as you have mentioned previously, that any drug would act in a certain way, in a positive way, if it's given at the right dose at the right time to treat what it's meant to treat. So if the benefits outweigh the concerns, then the drug has to be used and should be used. Aspirin is easily available. Aspirin promethazine has a wealth of knowledge of safety. It is a cardiac protective agent itself, so it could be used in COVID complications as well. People who are worried about protecting their heart in the long term, who had COVID, long COVID, etc., even then it's very protective. So to answer all those questions, I would say there are no ADRs reported. The trial went very smooth. There were no dropouts from the trial. All 60 patients responded. Results are phenomenal. There was no hospitalization and no deaths reported. So it's, I would say it's 100% safe and wouldn't see any contraindications.
Thank you so much, Rohit. Before I come back to Dr. Lalwani, just a question or two which is asked by the audience. Remember that this is Omicron is the predominant strain worldwide now, including India. And almost 80 to 90% of patients we are seeing are Omicron now. So it is rapidly replacing Delta. And as I said, that COVID essentially had three components: nose COVID, throat COVID, and lung COVID. Delta went right up to the lungs and the lower respiratory tract, while the Omicron variant is predominantly in the nose and throat. And in the nose and throat, each element of aspirinol has been thought to address those in a symptomatic way. So basically, decongestion is there, antihistamine is there, there is some degree of anti-inflammatory, anti-thrombotic, and antiviral impact is there. So it is faster clearance on the nose and throat COVID. That's how the formulation has been devised and developed. Having said that, Parag Waghode is asking a question which I will take. Do you see a more vindictive strain coming in the future? Unlikely, because as viruses evolve, they get less virulent but more contagious. But that's something which we'll ask Professor Lalwani. But Professor Lalwani, I have this question which Dr. Avinash Kinikar has asked. He always asks very good questions. That there's a BCG, and BCG has a lot to do with T cell immunity, which you talk about. And in India, we have the regular BCG for children, but we also have developed the RBCG. And Oxford Group has been working closely on this BCG. And I am certain that in your research in tuberculosis, there's a lot of innate and adaptive immunity. Does it have or indirectly confer a protective effect? And I just want to take you back to a story that when the early waves of COVID came with the ancestral strain, both Spain and Portugal had an equal degree of exposure. And if you see the Spain had a very high mortality, while Portugal had a very low mortality. And that is because Portugal is fully vaccinated with BCG at childhood, while Spain was not. That is one. Secondly, China and India also is a lot vaccinated with BCG at birth. And therefore, probably the mortality rate in India and China has been much less in the COVID space compared to the Western world, where BCG is not a standard of care. Do you really, and you have true insights in the immunology of tuberculosis, BCG, and its impact on COVID. So that's a little out of topic, but because people have asked the question, I thought, and when we have the world's one of the foremost experts in tuberculosis with us, we are very proud that you're of Indian origin. Would you be able to give us some insight in this?
It will be my pleasure, Dr. Joshi. And as the Indian Express headline said, about 20 years back when I invented the T-spot TB, it said, born in India, made in Oxford. So this is, in the BCG, the BCG is the most widely used vaccine in the world and the oldest vaccine in the world. And it wasn't actually until 2005 in my study in the Lancet where I showed for the first time that actually BCG not only prevents severe TB, as in disseminated TB and miliary and meningeal TB, but it also actually can prevent TB infection in the first place. So this was not known, but I demonstrated this in a large cohort of children in Istanbul who were exposed to TB in the households. And that study is a landmark study, and subsequently many studies have shown exactly the same. So TB prevents not only TB disease, BCG prevents not only TB disease, but it prevents infection as well. Obviously, it's not 100% effective. If it were, we wouldn't be having such a global chronic pandemic of TB as we do. But the fact that it can prevent infection opened up a whole new avenues of research, right? So firstly, there were lots of studies that corroborated my finding in different populations around the world. But secondly, it opened the door to a new avenue of research to understand how this could be happening. And this avenue of research, we already knew that BCG induces a good T cell response, but the new avenue of research that this inspired was to look at epigenetic programming of monocytes and macrophages. And it turns out that BCG vaccination induces long-term epigenetic reprogramming of the function of monocytes and macrophages, making them more effectively able to deal with, basically engulfing and destroying TB bacilli in the body. Now, in parallel to that, it had been known, and the importance of that observation is this, because it had been known for 20-25 years from studies in sub-Saharan African countries, particularly Guinea-Bissau, that vaccinated newborns with BCG, were not only at decreased risk of miliary and meningeal TB, as has been shown in landmark studies in India, but also of all-cause mortality, including death from bacterial pneumonia and death from diarrhea. So somehow, BCG vaccination at birth had been having these pleiotropic beneficial effects, decreasing all-cause mortality in African neonates, who are, as you can imagine, challenged with a range of different infections and threats. So this epigenetic reprogramming of monocytes, innate immune cells that BCG induces, could be the explanation for that. And all the observational studies implying that BCG vaccination may protect against COVID, if that is true, it would probably be explained by this epigenetic reprogramming of monocytes. But here's a question mark about the role, the potential beneficial effect of BCG in COVID. The study you cited, Portugal versus Spain, one country has BCG vaccination, one doesn't. Other studies comparing Northern Europe, Southern Europe. These are ecological studies. And ecological studies, while large scale, they have many confounders. And so you cannot really rely on them. They are best seen as hypothesis generating studies. There's another ecological study, Uncontrolled, which is the one in Los Angeles, where healthcare workers who had BCG vaccination before tended to get less COVID than those that hadn't had it. Again, an interesting observation, but it's ecological, full of confounders. If you really want to know if intervention is working, do what this dynamic Maharashtrian pharmacologist Rohit has done and achieved in a short time. Do a clinical trial. Do a randomized, double-blinded clinical trial, as was done in Lokmanya Hospital, as is coming out from Nasik, Kerala, Bangalore, with larger numbers, and then you will get the real answer. So I would say my conclusion on BCG and COVID is interesting observations in an ecological context, probably very confounded. I would wait for someone to do the trial to show the results. And in the meantime, frankly, we have vaccines that are good at preventing severe disease against COVID, if not infection. And now we have Asprinol 19 for treating the milder ambulatory cases in the community that the vaccine is not able to prevent.
Thank you, Dr. Lalwani. So final word, Rohit, is to you. As we conclude, I'm reasonably convinced that all these micronutrients in the right doses, in the right population, definitely have immunoadjuvant potential, whether it's vitamin D or a vitamin C or a zinc. How do you really collate all this? How do you really, you have a polyformulation now, and how do you feel that this formulation, which is there, how does it have a role, truly speaking, in this whole COVID space? Because COVID space is, as I said, it's a crowded space, but the Omicron space is really a symptomatic space. So in that symptomatic space, how do these little micronutrient formulas and Vitabiotics, I must say, has a unique distinction worldwide to know the right ingredients of nutrients, and they really have mastered that art. And Rohit, you are a part of that think tank. So could you tell us, we don't want a secret formula like the Coke formula, but we would like to know what is the science behind all this thinking in this COVID Omicron space? Because our current issue is, we all know that it's less severe disease, it's symptomatic. As Professor Lalwani said, if you have to go to hospital, well, that's not what we want. But if you are at home, you need quick and fast symptom relief so that you can go back to work early and quick. And really, you have tried to devise a formulation in that direction from a symptom standpoint. So what are your insights on the Nutri combo which you have? What went through the thinking and the science behind that?
As I explained in my presentation, Dr. Joshi, vitamins, vitamin C, D, zinc, selenium are all very strong antioxidants, anti-inflammatories, and general immune boosters. Clinical trials now around the world involving thousands of people have shown vitamin D supplementation and it prevents and/or reduces the severity of COVID-19. Studies conducted around the world, which we referred to while formulating, have shown up to 60% reduction in deaths with vitamin D supplementation to COVID patients. This is quite remarkable. Vitamin D is a regulator of the innate and the adaptive immune system. Again, we all know this. Although its immune modulation is related more towards its antibacterial mechanisms, vitamin D also has shown some antiviral activity, which overlaps with some antibacterial responses, such as induction of cathelicidin and defensins, which can block viral entry into cells and its replications. Induction of autophagy is also a cellular response to vitamin D levels. And then vitamin C has known for its antioxidant, anti-inflammatory, antithrombotic, and immune modulatory function for years now. Role of vitamin C in the prevention and treatment of pneumonia and sepsis has been underway for decades. And this research has really laid a strong foundation for translation of these findings into patients with COVID-19. Zinc, it's very essential to preserve natural tissue barriers such as the respiratory epithelium. I remember this point raised by you, Dr. Joshi, in one of our late night discussions about how it really stops the entry of virus into a cell. And you very kindly explained me that a few months back, that it has that barrier effect as it works on respiratory epithelium for a balanced immune system and for the redox system. And zinc deficiency can definitely be seen as a predisposing factor to not only this, but many viral infections. So all this put together, when you use vitamin C, D, zinc, selenium, nicotinamide, which is vitamin B3, again, a very strong antioxidant at the right levels and optimum levels, and use the data that we have at hand, it makes a very powerful combination that we have used along with aspirin, promethazine in Aspirinol 19.
Thank you, Rohit. So I think as we are concluding, just two passing questions and concluding remarks from Professor Lalwani. First one is, do you think that we might get a sinister variant? And your last take-home message for our audience. We are really grateful to you that on a Sunday you have volunteered your time for this cause. So we are really grateful that you could participate in a very active and a fruitful dialogue. So just two small little points. First one is your thought: will there be a little more crazier strain than a Delta or Omicron? And second is your take-home message.
So, in terms of the future strains that are coming, look, you only have to go back less than 3 months to October, early November. No one had even heard of Omicron. So to predict SARS-CoV-2 future variants is difficult and tricky business. And no one predicted Omicron in October. Next month it was there, and it's now spread all across the world. So I think all we can say is this: there will be more variants, and I think you described the trend correctly, Dr. Joshi, when you said that the overall trend will be towards variants that are more infectious but less virulent. And this, of course, is what was seen with flu over the last many decades. And it's the tendency of a virus to adapt to its host. So as we know, SARS-CoV-2 jumped into humans for the first time about 2 years ago. And we have seen this incredible global natural experiment in the global population, where a new virus enters the human population, and over 2 years, we see with successive variants how it becomes more and more infectious and transmissible, but less virulent. That is, after all, adaptation, because the goal of the virus, as it were, is not to kill people. The goal of the virus is to replicate and spread as much as it can. So if it can reach a comfortable equilibrium with the human host, where it infects people, transmits widely, but doesn't kill them, that is really, in a way, the direction of travel for the evolution of the virus, which you nicely, succinctly put yourself earlier. And the second question, Dr. Joshi, if you wouldn't mind, please repeating it.
Your final message for the audience.
Sorry, I just couldn't hear you. The line went bad, but I can see you clearer now.
The final message for you. Take-home message.
Take-home message. No, I would say that the take-home message, I'd like to make 2 take-home messages, and one of them is about you. And the first take-home message is to, in 2 years, science has delivered incredible advances to help us combat this pandemic. So what I would say is the take-home message for this audience, which is practicing doctors, is use the available tools based on the evidence for them. So science has delivered us a great toolkit now, and let us use those tools and let us keep to evidence-based interventions, such as those described by Rohit today with Asprinol 19 and others. And let's use that toolkit instead of speculation. Let's use what we already have, because from having nothing, we've got now a pretty good toolkit with vaccines, treatments, and so on, as we've been hearing. And the second take-home message, as I said, relating to you personally, is because I think, Dr. Joshi, you, in your role in the National COVID Task Force in India, you symbolize that, because you're really advising, helping, urging, and persuading not just clinicians, but also policymakers to use the right tools that are available to combat the pandemic. So I think your own work with the COVID Task Force is an excellent model of what can and should be done now.
So thank you so much. Rohit, any final comments from your side? And then I'll take a quick minute on summary. We are completely out of time. We have tried to answer as many questions as possible. Final word from Rohit, and then maybe just a summary line from me.
The final word will be just what I said when I summarized the presentation, that you really need something for a symptomatic relief from COVID, and so that the progression doesn't reach a stage where you need hospitalization and supplemental oxygen, and could cause fatalities. And Asprinol 19 delivered all that. To summarize everything that you've said, Professor Lalwani said, I've said, we've got a combination with a unique combination, reusing the drugs that are easily available, accessible. We don't have to wait for years to, for another antiviral to be developed, for it to only fail or not work to our expectations. We have aspirin, promethazine, widely used, very safe drugs, a lot of knowledge we have about how they work. We have now seen the pharmacology of how aspirin could work in COVID patients by the COX-2 inhibition and reducing prostaglandin E2 and all of that we discussed, plus the unique combination of vitamin C, D, zinc, selenium, and vitamin B3. I think this is an easily accessible tool that should be straight away put into practice, and I'm sure that will not only help people in India, but also overseas when we launch this product all over the world.
Thank you, Rohit. So thank you, Professor Lalwani. He is the immunological man of the world, particularly in the infectious disease space. He continues to do some cutting-edge work, starting from his journey of tuberculosis now in the COVID space. And his talk on T cells was very insightful. Remember, even if your antibodies decline, you still have T cells, which are memorized. And that was his take-home message. And secondly, he also told us that when we have simple tools to use them well, use them in cases. Rohit told us symptomatic and syndromic care is all about early treatment, appropriate treatment. And my final take-home message is behave responsibly. It is crucial now as we evolve in this pandemic after 2 years to save every life. So if there's a red flag, if you're into a severe category, if you're deteriorating, go to the hospital. Most people, most of the time, will be managed at home, but they will need direction from a medical doctor. So be guided telephonically, telehealth-wise with a doctor. So that's something which we need to do. And don't forget COVID appropriate behavior. Don't forget air ventilation. Don't forget your masking and vaccination. They are as important as symptomatic treatment. They are as important in triaging the vulnerable groups, the comorbid conditions, and our senior citizens, as Professor Lalwani said. So stay safe. I think we are looking at a horizon where the virus mutations might be more transmissible but less severe. We are looking at an evolution where there could be a possibility of the disease becoming endemic, and we are looking at a possibility where there would be some immunological tools like vaccines. There could be symptomatic tools, like Rohit are innovating, and therefore ultimately we still will need to continue what we are doing it correctly. We are prepared from the healthcare side. We need, of course, cooperation from all our citizens across the world. And remember that no one is safe till everyone is safe. So I think that's really the key. And remember that these type of waves are like hurricanes. And these hurricanes, when they keep coming and going, when they are gone, it doesn't mean that we are not prepared. We should always be prepared, because we are going to keep on getting these hurricanes over the next couple of months to couple of years. So we definitely need to be alert, cautious, but not panicking. That is really the message for the day. I once again thank Rohit, thank Professor Lalwani, and thank Vitabiotech and Mere Organics. And I also thank from 1MD, Dr. Anirudh Sapadnekar, for conducting this program. I thank the Vitabiotech team from India, Uma Madam and Rajesh, and everyone else which is there on the team. They have done a wonderful job for conducting this meeting. And our whole ambition is to ensure that science and education is the key, because there is a lot of clutter. We need to declutter information. We need to detox digitally. We still need to eat appropriately. We still need to conquer our non-communicable diseases, because they form the milieu which makes a simple virus like Omicron kill. So it's very, very important that we still continue our lifestyle advice. Independent of the micronutrients, independent of symptom treatment, we still need to eat right, walk more, sleep well, and smile. Thank you very much, and a happy 2022 to everybody.
Thank you. Thank you, Dr. Joshi. Thank you very much. Bye-bye.